Buddy. Thanks, Kev. Hi, everybody. My name is Richie H., and welcome to The Other Side, our podcast at Blue Crest. And I've got an esteemed panel of guests with me here today. And I'll start down in the corner with Dawn Bellamarch. Dawn is an LPC, LCADC, and ACS. She's also a lot of letters. She's the CEO at RCA Lighthouse, and that's in Mays Landing. Hello, Dawn.
Thank you.
And then we've got Mike Carl, Senior Vice President at Delphi Behavioral Health, a.k.a. Serenity at Summit, for anybody who knows the field. Mike is an MHS and an LCADC. And then I've got our friend to my left, Julie Reardon. Julie is an LPC, an LCADC, ACS, NCC. She has a private practice here in Wayne, New Jersey. She also does crisis intervention and peer recovery at a local hospital. I guess I should introduce myself for anybody who's not seen our podcast. I'm Richie Hession. I'm the CEO at Blue Crest Recovery Center. And thanks, everybody, for coming.
Good to be here.
So today's topic for today's podcast, very relevant, is COVID-19 and the effects on our field, and the effects on us, the effects on our clients, the effects on their families. The effects have been in every walk of life. The effects have been astronomical, COVID-19 and everything that it's represented to us societally and specifically to our field. It's been unbelievable and far-reaching. And so, as we were joking beforehand, we could each talk an hour and a half and not even come close to touching the effects that COVID has had on us, each personally, on our respective places of work, on the clients and families that we've dealt with. So we're going to kind of hit on a few different things. I'm going to kind of pop around. Anybody who's watching, we can be found on Facebook, SoundCloud, YouTube, Spotify. And if you want to ask any questions, because we are live, you can sign into your YouTube account using your Gmail, and you can fire out questions. And Nick, our right-hand man, Nick Tamaro. Nick, yell hi to everybody.
Hello.
Hello.
Nick.
Nick will yell out any questions he has. He'll say, hey, Rich, we have a question. So to set the stage for this particular podcast, I usually set the stage for kind of what it's going to look like, and for us, it's usually educational. We usually do these thinking about perhaps people could learn something about whatever the topic is, and we go at it from that perspective. And not that you couldn't learn anything about this today, but really you learn more about what we've kind of been going through. I was jokingly saying that it's more like a commiseration podcast taping, but I think if I had to gear this towards somebody to show this podcast to, it would be to policymakers, politicians, local health departments in the country, for what the effects have been on us in the treatment world and on the clients, and what we have to deal with day in and day out, which is why I have these folks who can speak to personal experience. So we're going to do stream of consciousness, right? I don't have a list of 500 questions that I'm going to ask you guys. I want your experience. Like, we don't have scripts where, we're going to speak, for real. Like, we're going to talk to you about our personal experiences and what we've dealt with and what we've seen. Dawn, I'm going to kick it off with you down at RCA. Detox res level of care, that's detoxification and residential treatment. And why don't you, if each of you, when you kick on yours, she's going to kind of talk about detox res, so she'll explain it for you. Your private client stuff, kind of just a brief for people who don't know, right? Because there's some people who might not even know our field.
Right.
Just a quick, what does that look like? Detox res, what does that mean? What does that usually represent for a typical client when they would come, how long they'd stay, and all that? And then tell us, COVID, how it's wreaked havoc in your world in the last year and a half now.
Sure. So as you pointed out, RCA Lighthouse is a 133-bed facility, Mays Landing, New Jersey. We offer every level of care. I'll let you touch on the IOP and partial care and things of that nature. But for me specifically, detox and residential level of care. So detox, typically 5 to 10 days, really a medically monitored, opportunity for patients who are struggling with certain substances to come in and really have that nursing and medical oversight to be able to safely withdraw and manage their detox process. Residential treatment is just an extension of that, right? We really want our patients to complete a full 30 to 40-day program, helping them stabilize before they set off into the other levels of care that you're going to hear about. I've been at RCA Lighthouse for almost 5 years, starting as the clinical director and then progressing to CEO in the last year and a half. And COVID made things very interesting, as it did for all of us. We are dealing with a drug, an epidemic really globally that we've been dealing with for some time, and then add into the mix a global pandemic. And really, I think the word that I would use is pivot. What we've had to do pretty, exceptionally and almost every single day is pivot in how we provide treatment, right? Is making sure that we're safely testing our patients and adhering to protocols while they're there, but that we're not minimizing their substance use disorder while they're in the facility. I think, when a pandemic happens, and it's the first one any of us have lived through, and God willing, the last one, you learn really quickly that there's going to be some factors that are going to potentially get in the way of how you deliver your standard service. So as a treatment provider, especially in the level of cares I'm in, I would say, pivoting every day to make sure that we were prioritizing the disease of addiction while keeping our patients safe from the pandemic.
And if I could, I just want to throw it in there again for everybody to really kind of give that some context is, she's talking about prioritizing the addiction. 93,331 people died in 2020 of overdose deaths alone. That's just overdose deaths. That doesn't come close to touching all the other alcohol and drug-related deaths that happen every year in the United States. Hundreds of thousands of people every year. And we've been dealing with that year in and year out forever. And now along comes the COVID pandemic. And the COVID pandemic, and you guys could speak, you would think that it might affect our people a little bit more because we're usually kind of, headed, we're usually on the edge of that sickness and the unhealthy lifestyle that comes with addiction and alcoholism. But I don't know that it's really more towards people with autoimmune, the elderly, people with other kinds of diseases, not necessarily addiction per se. So the danger for us remained the entire time our addiction.
Right, and I think that was the number one thing I saw very early on, right, was we had an opportunity to either allow something to take, and it's very important, right, keeping our patients safe and the health and welfare of everyone, but we had an opportunity to really make sure that the substance use disorder was still at the forefront of what we were treating and what we cared about. And, I could speak for a lot of our partners, everyone at this table, certainly. The way we handled it was great. Right? We really took a second to pivot, again, to say to ourselves, what do we need to do to make sure that 93,000 more people don't die because we're paying attention to this over here. And, I think as a detox residential provider where our patients are staying in-house with us, it's more challenging than ever, right? Because all these things are on the news, all of these requirements are coming out, our patients and their loved ones are seeing all of these very scary things. And, it's challenging. I think the responsibility we had as providers was to make sure that we didn't forget about, the disease of addiction, which is one that, we've been fighting for decades, as providers now and centuries, for forever since the dawn of time, right, as a society, is that making sure that stays at the forefront. And I think it's a task we're still going to be, required to have to look at and see what we do moving forward.
Did you guys have staffing problems as a result of COVID? People who were told that they had to quarantine. I mean, your staff has to come to work.
Right.
You can't just leave 133 clients unstaffed.
Yeah, that wouldn't have been cute.
People have to be staffed. But, according to what the government and the health department had laid out, if you're even around someone with COVID-19 that you have to quarantine, I'm talking pre-vaccine, early days was a little different than post-vaccine. The rules have changed along the way. It was no mask, then it was masks. There was no vaccine, now there is a vaccine. Obviously, it's been changed, but in the beginning, I remember, and you tell me if it was your experience as well, in the beginning, staffing was a big scary point because if people were required to quarantine and you happen to get unlucky enough to have a bunch of staff that was around somebody, how did you guys manage that?
So you learn a lot of things quickly, knock on wood, because I don't know what the future brings, but I would say at Lighthouse we were very fortunate to not experience any staffing issues that truly got in the way of patient care. Reason being is because we really prioritize cross-training in the beginning of this whole thing, right? So if you are a human being with a pulse in the building working there, you knew how to do various disciplines. You could run a group, you could do an admission, you could run, a primary, right? Anything that you're able to do that was going to help our patients get well. And I think it helped us when we could have potentially experienced staffing problems, not run into a major issue. Outside of that, I'm not going to lie. We experienced the same struggles that everybody else did, right? There's contact tracing that your county requires. There's things your state require. that, can make it challenging for you to, staff your building at all times with the patients that need addiction treatment. So, it was a day by day. I think at some point for me as a leader in this space, I kind of just relinquished knowing what's going to happen next week, like for forever in a day, one day at a time. I'm going to wake up, I'm going to come in today, and whatever I have to deal with today is what I'm going to deal with. And we figured it out, but that is not, I know that that's not the experience of every inpatient facility. And like I said, I think having 5 years with a lot of the same team created a culture where they're bought in. They're going to show up. We're going to do it together. And unfortunately, we were able to provide our patients with similar care, and the standards that we've come to be known for. But it's hard.
Did you find that COVID created a lot of, I know you did, but I'm asking it as a precursor to a question, but I'm sure you found that COVID created a lot of fear and chaos, right?
I think that was the number one thing.
Right.
Outside of the staffing, when you talk about staffing issues, the number one thing was the support we provided. So it's one thing to have people that don't want to show up. It's another one that have people that show up that are constantly scared of what's next.
Sure.
There's TVs all over the building. They're going home and they're being immersed in social media, and this is what's going on in your state and your county, and there's this variant, and
the news channels had current death counts.
Yeah, and every
second
and
it
was like the red ticker.
There's death everywhere. There's death everywhere, and it's just absolutely
scary.
brutal. Now that's and that goes on both sides. It's not just your staff, but it's your patients as well, right?
And I think that the part for me that was really important was how do we provide the support for our team, because this is what they're seeing. I can't prevent that. I can't move into their homes and see what they're scrolling on social media, right? But like every day being like, listen, trust me, we're good, we got this, right? And creating that culture inside that trickle down to the patients. Our patients are struggling with things that are inevitably going to kill them if we don't help them take care of it, right? The last thing I wanted was additional fear to get in the way of that.
And I'd love to say, and Mike, I'll go to you on this too, because I know you saw it, but I'd love to say that, I wouldn't love to say, but I'd be tempted to say that a lot of clients used it as an excuse. We deal with that every day. People come into treatment, and we deal with people who have built-in excuses. I can't stay. I got to get my life back.
Right.
I got to go all counter to what the reality is, which if you really want your life back, you'll give up the next 90 days so you can have the next 40 years. But that's a different, it's a different
Not
argument.
using logic.
But now these folks are coming in, and they have built-in reasons and excuses. Oh, this COVID, all these people are dying. I got to get home, And so it became all that much more. Mike, you can speak to it. Did it become all that much more difficult to ACA block, which is leaving against clinical advice? But did it become more difficult for you guys to manage the clientele that was there?
It did, and going back to what Don was talking about, the employees, they're managing their anxiety and fears with the news channels, creating it daily. But keeping them in place. We had several staff members that were seriously ill early on. I remember, the pivotal point for me was, I think it was February, it was right before this got bad. Our medical director, who's of African descent and worked with the World Health Organization, looked at me and said, 2020 is over, right? And I was like, come on. My
Right.
practitioner, a big group, I won't go nameless, said, oh, this will blow through in a few weeks. And here's the guy running the detox facility saying,
Right.
This is going to be a huge impact. You have no idea, because he had seen it in Africa, and it was coming his way. But we found challenges in every aspect, especially maintaining client contact and with the ACA blocking and maintaining the families. We found it extremely difficult working with the families because of that disconnection that was caused by we couldn't have family groups.
Right.
I don't know if you guys had family groups, but we didn't.
Huge deal. Huge deal. Cornerstone of our program.
So you're talking about the treatment that's based in accountability and client accountability, unable to use those collaterals that we normally use, right? And staff not going out of their way to endanger themselves, but trying to motivate them to continue the pursuit. They give it all, but at the same time, managing them to do their job the way they did 12 months earlier was very difficult.
Now, in residential care, usually, I don't know, do you do visitations in residential care? Pre-COVID, do you guys allow for visitations in residential?
We did. Detox was basically blackout, but residential, we're just starting the family program over again.
So, but you typically have always had where families come in, and it's a big, that's what you're talking about, PHP level of care when it's downstream to us. it's a cornerstone of what
crucial.
we do. Family involvement is everything.
Right.
It's our biggest night. Right, at Blue Cross, our biggest night is Wednesdays. Wednesday night's awesome. We bring all the existing clients in. We bring alumni. We bring all the families for family group. We have food. Everybody comes in. They do multi-family groups. They have a big speaker come in at 7:30 that does an hour, usually a rock star speaker. The families get to sit with their family members and hear like a kick-ass speaker who's had like a real 12-step experience, which is like we're big fans of. To see them all get together in that way, to see the hope, that building was on fire every Wednesday. I used to look forward to every Wednesday night. Gone. In an instant,
So
gone.
I'll tell an anecdote with that. One of my first clients early on, I was working with Charlie Stuckey, and the family dropped him off to me at like 40 and said, I'll never forget this moment. He said, we want nothing to do with him. He's yours. You know, I don't want to talk to him for a year. And I remember giving him his 90-day pin at a meeting he asked me. And every one of his family in the back of that room, craning to get a view, and his mother.
Love it.
Right? I mean, that's it. You know,
That's the hope.
the restoring of that family connection is everything. And COVID isolated them. And I felt sorry for them, too.
Sure.
Because they were at home or normal, sometimes beyond what they should have been. And they should have been in a facility. And they take hostages, not family members.
And this is kind of a cool segue to Julie because, and I know you deal with all different aspects, right? And so, you know, I'm sure your private client side, you see people of all ilk, right? Because you don't only deal with addiction, right? You have all sorts of. So, but I would ask you from your experience on the client side, to what Mike was speaking about and from what we saw, now there's total isolation. Addiction's already a disease of isolation, but now the families, which for us, family members watching, I think family members are affected worse than the addicts and alcoholics themselves. I think it's
100%.
harder on family than it is on us, meaning as somebody who's in recovery, a former addict, alcoholic. But the family, the struggles the families go through, did you see a lot more of that? Did you see a lot more on the private client side and from your colleagues? What did that look like on your guys' end?
So for me, I'm associated with a treatment center in another state through their family group because it went virtual. So that treatment center took their family group and they went virtual. So the director of alumni and family programming, he developed that virtual platform for the families and asked me to be a part of that. So I guess right after COVID, maybe April or May, they maybe even earlier than that, they started doing their family group virtually, and they've had up to 30 family members attend that group. And funny you say Wednesday because it was Wednesdays. So that's one part that I saw. So that treatment center kept their family group going virtually, and it was well attended. For me, with my private clients, I recognized that Al-Anon and Families Anonymous went virtual. So did AA and all of the A programs. But that's where I sent people. Families Anonymous I can't say enough about. It helps families tremendously. Al-Anon does as well. So
if you could educate me, and I'm sure other people, Al-Anon I know, right? That's family. But what is Families Anonymous? I don't know that I'm familiar with it.
Families Anonymous.
Hold on. Are you familiar with Families
I'm very
Anonymous?
much.
Are you?
I am, yeah.
Damn you both. Go ahead.
I love it.
Hear more about it.
Right?
A little more hands-on.
I should
Yes.
know this. It's kind of aggravating.
So Families Anonymous, their meetings are about 2 hours long. So the first hour, everybody signs in. The first hour, they go over a step. And then I guess the more seasoned individuals will talk about the step in their experience, you know. And then the second half is when you sign in, you ask if you want to speak, right? And then the leader of that meeting will kind of say, okay, Dawn, you said you wanted to talk about what's going on. And then you have a platform to share the pain that you're going through. You know, and it's not only the pain too. It was some of the families that have success because the other families need to know that there is successful recovery for themselves as well as their loved ones.
Is it specific to addiction or mental health as well?
Addiction.
Straight addiction. Okay.
Well, behavioral,
Yep,
but
okay.
behavioral because of addiction.
Yeah, fair enough.
You know?
Addiction first and then
Yeah.
co-occurring second kind of thing. Like
Lots of parents, you know, some siblings, some other relatives, but it's
Mostly parents.
mostly parents, and it's just an amazing recovery program. I can't say enough about it. So
Okay.
check it out, familiesanonymous.org.
No doubt.
I have nothing to do with it,
A
but
plug.
Now, so to that, you brought up virtual, and I'm kind of curious what your experience was. We did the same thing. Obviously, we rolled with it, and we went virtual with the family night. And at first there was like that pause in between where no one knew what the hell to do.
Yeah.
We were still trying to figure out treatment. Never mind family groups.
Right.
Like that was almost. It's an aside. It's the most important thing, and yet it becomes an aside when it comes to just the actual treatment and figuring out. Keeping in mind when COVID hit, all the rules changed. Everything started off and nobody knew what to do, and all of a sudden they're announcing mandatory 2-week quarantines, but you weren't allowed to do telehealth from our perspective. So if we're supposed to quarantine and we're not allowed to do telehealth in addiction, and you're not allowed to go into the sober homes because there's rules in New Jersey, then what are we supposed to do? You
Right.
can't send addicts home.
Right.
You can't say, all right, everybody, time out. Unfortunately, COVID doesn't
more
trump us.
addiction.
They think it trumps us, but they're wrong. Because we already knew that we're going to have 200,000 plus deaths last year, more than that probably, right? 70,000 overdose alone, 93,000, 70 the year before, and in the high 60s the year before that, 2 years in a row. But that's just overdose deaths. That's not all the other deaths put inside. So we don't get to do a timeout, right? So for us, we knew that we're going to have to deal with that from Jump Street. Anyway, I really want to stick with the virtual part versus the live treatment, right? Because we rolled with it, and we eventually did get into that, and we set up virtual, and then thank God the insurance companies, all the policies, folks, your policies have to align so the insurance companies are able to pay for people to be able to do that virtual treatment, and so the places can stay open, right? And so the health department and, with your state and the federal government and the insurance company policies all have to align. And when those things are out of line, which really they are right now, I don't know if anybody knows that, but in our
Right.
level of care, that's all misaligned. All the insurance companies are starting to do away with telehealth options. They've taken away mask mandates, but they're still requiring 7-day with a test quarantines if you've been around someone with COVID. So if you have to lock down for 7 days and you're not allowed to bring treatment then into whatever sober home, whatever place that
Right.
they're at, and telehealth is no longer an option to be able to provide them treatment, what are they supposed to do? So how do you manage something like that, right? Deftly.
Yeah.
But even without the alignment of policies and the ability to do that, even when the policies were aligned when it comes to virtual, I found, and I would love all three of you take on it for whatever experience you've had with the virtual, I've found that, and for you doing private client stuff, seeing people when you're a clinician, and all three of you are well clinicaled, well credentialed, you guys, there's not just spoken language, there's body language, there's, sitting across from someone and being able to see all of them is the most effective way for you to communicate and see what's actually going on. A lot of times their body language is say more than what they're actually telling you. That's gone now. Right now, all of a sudden, you've got the fit to a large degree, or you seem to disagree. I'd love to hear that you think virtual is as effective as live. Tell me how's that the case?
So for my private practice right now, I'm 100% virtual. I personally don't have any difficulties with looking at someone's body language, determining, like what they're saying is not what they're saying. So I really don't have a problem with it. I had very few clients who have a problem with it. And it's really some of the younger people in recovery would have liked to be in person. But for me, I haven't had any difficulties with any of my private practice clients with virtual. I kind of like it.
Oh, that's interesting. And what about you guys?
I mean, I can just say for me, we are doing a lot of virtual, specifically in our outpatient level of care, and we're doing all of our family visitation on the weekends virtually. So one of the pluses that came out of COVID, right, was this ability to still do these family visitations in a way where they don't come maybe to the facility. And in a residential level of care, sometimes that's a bonus, right, because there's no mixing and mingling, right? So I mean, it was a bonus, but I think I agree to your point, right, in some extent, is where there's so many positives, but for the patient who benefits from that. There are a lot of patients I've seen that just need the accountability of showing up. They need the ownership of seeing a person every week and saying, I came to the facility and saw Dawn, met with Dawn, as compared to logging onto their phone where they're not as accountable.
Well, and so we could differentiate the levels of care as well, which I wasn't really doing. But on the private client side, they're kind of signing up at that with a different mentality
Right.
than, say, someone at IOP.
Right.
At IOP, what we dealt with a lot of, which you wouldn't deal with a lot of, is people signing on, and then they put the screen up so
Yeah.
you can't see their face. And
Yeah.
you're like, dude, where are you? We can't count you as part of this
Yeah,
group.
yeah,
Where
yeah.
are you?
Yeah.
And, maybe it just goes to their initial, and now you're
Yeah.
calling them saying, dude, you got to get on group. You got to get on group.
And I think that that's why a lot of, and we're exploring this, like RCA as a company as well, right? It's such a tremendous asset for the patient who's ready and there. And who, has these other barriers for the patients that need to physically be present for that accountability because they're early in recovery or there's significant stressors at home or wherever their safe environment is, right? The face-to-face is still the value add. It's still the same thing as it's always been, which is rapport and relationship and seeing body language and someone being able to come in and say, this was my experience. I met with Dawn. I got her vibe, right? Her whole aura. I was with her. But, on the private practice side, I see it as well. A weekly session is a great way to stay in touch with your therapist and not have to drive 25 minutes, right? And to still get the experience and work on treatment goals and continue to make progress because that patient is appropriate for that setting. I just think it is the old school, kind of different strokes for different folks, right? It's where you're at and what is going to help you get to the goal line, which is long-term recovery. And it's not the same platform for everyone.
Right. I've also found that I see clients from all over New Jersey that
Right.
weren't able to find a therapist.
Sure.
No one was in there, available to them, and so maybe I was down the list a little bit, but I was available. And so I think, the availability part of that as well, for me, it worked.
Yep.
So, but for the higher level of care for outpatient and intensive outpatient,
Right.
they're starting to discontinue the allowance of telehealth for that. Private client, they've always allowed for that to a degree, right?
Yeah.
Or at least since things have become more
Right.
technologically advanced. But for our level of care, they've continuing to do that where more people, and to that end, where it's available to more people that might not have sought it out previously, there's also a lot more people right now that have been affected because of COVID.
Right.
That would never have been affected before, like the
Agreed.
cops and teachers and everyone,
Older
basically.
adults.
But all this stress and all this chaos with people who are working from home, they're drinking more, they're doing more drugs, they're to numb the fear, the constant death toll on
Isolation.
CNN and blah, blah, blah. We've seen people coming in for reaching out for treatment that have crossed the line that might not have crossed the line
Agreed.
up until this
Agreed.
point. Have you guys seen that as well on your end?
We have. I've seen more and more acuity, especially mental health, on our admissions coming into detox from year over year. People just much more anxiety, depression disorder than the year before. And I don't think it's just we're seeing a different population. We're seeing the same population, just with more acuity. And again, it's that if the fear is rooted in anxiety, fear, and isolation, we got plenty of that last year.
Right.
As far as telehealth, I'd like to just, I think, as you said, it's up to the provider to thine own self be true, right? If it's working, but it's up to us as providers, if it's part of the ongoing landscape, to make sure it is effective and how we do that. And we, in our
Absolutely.
IOPs, have been, a bit of a hybrid, a little bit of both. It also, helps with those shifting and different work schedules. Geographically, they're a little further. Like I said, I've been in some self-help meetings. There are people all over the country.
Right.
I mean, it's brought people together as well. But I actually think, I know the payers are pulling back, but I think it's part of our landscape for a while, and it to some degree. And I think it'll come back. I think they'll be pushed back here. If I think
Perhaps
they're going to have to.
Maybe a little chaos in between. I mean, again, and I'm speaking from which I want everybody here to do always. Every time we have these, that's why I love doing them. You put it out on the table, and I speak from my experience, and I speak my mind. I don't, niceties have never
that.
stopped me before.
Niceties.
And so I'll just tell you that for me, I'm a recovery guy, right? So I do 12-step fellowship on the outside, and they've all gone Zoom. They had to.
Right.
The church has shut us down. Can you pass me one of those waters?
Please.
And I think the one on the end is for Julie, in case she wants.
Thank
a
you
nice
very
cold
much.
one. So for me, doing the 12-step stuff, it was great I don't have to leave my house.
Right.
I can literally, and most of us sit in our underwear because you only see my face,
Yeah.
or I put it on my Ireland. I've
Yeah.
gone to meetings all over the world, and it's pretty cool. It does not replace live meetings, period. You
Yeah.
can disagree with me, and if you do, you're wrong as far as I'm concerned.
Right.
Now, other people will disagree with me, and I've had these conversations where people are like, you're wrong. I love doing it virtual, and I don't even want to go back to live. I don't agree. I don't agree at all because there's magic that happens with human beings when we get together, that communal sense of being with one. And I've worked with hundreds of people personally on the
Right.
kitchen table out of 12-step programs. And for me, virtual, like I won't sponsor somebody long distance because we need to be able to commune. We need to be together. I will say the same thing goes for, as a temporary thing, it's been great. From a business perspective, I get it. Everyone, most of the companies are like, listen, from business perspective, it's easy. It's
Right.
simple to maintain. I can have a bunch of people on there. It's easy to do. The clinicians can just show up. They do the thing. You sign off. It's simple. It's clean. It's easy. I don't do simple, clean, and easy, right? I want it to be dirty and difficult and effective. And so I'm not saying it has no effect or it's not effective at all. And everyone's experiences are different. And it sounds like Julie has really adapted well to doing those kinds of sessions and the way she carries them out for IOP level of care, PHP, IOP, and to maybe a little lesser of extent OP, but I think it's totally necessary
Yeah.
for me.
At a minimum, some contact and that accountability is, but I think it's also knowing the client, right?
Sure.
Dawn said it earlier, where is meeting this client where they're at, not where we're at.
Sure.
As
Right.
Where we
providers.
want them to be at.
Yeah, where we want, if there's 10 to 15% of the population in a country of 300 million, that's 50 million people.
Sure.
I mean, not everyone's, has the insight, the motivation, or anything to be able to do it virtually.
Yeah.
Or technology knowledge.
Well, and that's a big
we've all read
problem
the
as well.
story of the guy who, sent away for a big book early on in the Himalayas or wherever he was, and he did well that way. That is the outlier
Right.
of this disease.
Sure. No,
Most people
fair
don't
enough.
want to be here.
But
You know.
to Julie's point, more rural communities don't get the benefit
Right.
that
Sure.
the
The amount of
bigger
patients
cities
that get treatment
Well,
now.
but think about rural communities that don't have great internet signals. Quite frankly, if you're talking about
That's a-
technology,
that's a big
there's a
issue.
lot
Yeah.
of rural areas
True.
that don't have great internet
True.
signals that have a hard time. For as many additional people it's helped, it's probably cut off that much more that you don't consider or that you don't think about, which is the point of the podcast,
Right.
is the effects that COVID have had. And you were right. You said it's the law of unintended consequences. And so there have been some positive effects from
Right.
all of this with COVID. And I'll speak to one of the 12-step fellowships. I just found out this the other day. One of the 12-step fellowships who had been struggling financially, you would have thought they would have been in the tank right now because of everything that got on. They've gotten more money than ever they have before in history.
Wow.
Because people were no longer paying rent out of the churches. They were doing it all on Zoom. All the
yeah.
money got
That was
kicked
90% of the
upstairs.
expense. Right?
Holy cow. So
Wow.
they ended up doing much
Coffee
better
and
than you
rent.
would have
Yeah.
thought they would have done. And again, a lot of people raved about the online meetings and such, right? So
Yeah.
that's really been fantastic.
But if you were early on, that would be.
Forget about it.
Forget
You know,
about it.
there's people
Right.
who've come and they're celebrating like a year and they've never been to a live
Physical
meeting.
meeting.
And
I had a
That's
client like that.
amazing.
That's crazy stuff,
Yeah.
man.
That's amazing.
That's crazy stuff. It really is. So I get that there's been some positive effects on some of it, and it has made things for many people more accessible. And then in other circumstances, it made it less.
I think if we always, because one of the things I tried to focus on early on is, right, as an organization, we use telehealth and we use face-to-face, right? I oversee a residential program, so the patients are there. You can't lose that fellowship, that connection, that one person who said something that was the light bulb that sticks with you for the rest of your life. But you're right, like there's a piece where it's like, okay, we just opened up this whole new world. And it's embracing the fact that, like, if we stay focused on the why, which is helping people for their long-term recovery, right? Like, that's the why in my head. That I'm going to align them with the platform, face-to-face, virtual, whatever it is, that's going to help them get to the promised land. It works. Because you're right, there are people accessing treatment, and I'm seeing much higher acuity in older adult population, without a doubt, that have never accessed treatment before. And if they're going to do it via, their Verizon Wi-Fi, have at it. Saddle up. I'm here for it, right? But it's also, we have to be the owners of knowing that we are aligning our patients with the best platform for their long-term
For
recovery.
them.
Not for what we want it to look like, but what is going to get them there. I think we have that responsibility.
Yeah, I guess time is going to prove it out.
Yeah.
What's effective? Can you really tell me that in a year? in a 1 year swatch.
need
It's
more
not a
data
big
than
enough
that.
data set,
Yeah.
right? It's not a big enough
Right.
data set. It's
I think
just
the
not.
impact of COVID will be here for years, decades.
A decade at least, I would say.
Yeah.
I'd say you're right, in ways that we still don't even realize that it is going to still and has already affected us. COVID's ongoing. It's not going to go away, right? There is no, I know this whole thing, we don't get into politics on this podcast, but the whole thing about being completely eradicating COVID is fantasy land. There's no
Right.
such thing, right?
Right.
Unless we shut down all of human society and everybody goes in a cave. I mean, it's just not going to happen. We're going to learn to live with COVID. And that means we are all going to learn to live with COVID.
Mm-hmm.
You've already adapted to, and as have we all, in whatever fashion we can. And again, I'm speaking from, of course, we're utilizing it because
Right. You have a choice.
this is what we need to do. We
Right.
will meet them where the situation
Yeah.
warrants. I'll do anything to get treatment to my people. Anything. It makes no
Right.
difference. I guess what I'm saying is there's a quality thing there for me. My own assertion as to what I consider to be quality. And I'll tell you that when we went fully virtual for a period of time with IOP, and then those folks who'd been going to IOP for a period of time, and we were like, we're opening back up again, clients were clamoring for it. You know why? The isolation.
Isolation.
See, the isolation's not a friend of addiction.
Craving it.
Families, different thing. They have different addicts. Isolation is not a friend of an addict.
Yeah.
And so getting them to come in, they wanted to come in. Some of them didn't want to, but they did, if you know what I mean. They absolutely
See what
wanted
the
to do
world
it,
want.
but they still, somewhere inside, they know they needed to come
they
in.
know they need to.
Did you ever have the experience? And we did. We met a client that had been doing just virtual for 4 months. They come in, they meet their counselor, and they start crying and hugging them because of the personal contact.
Right,
That
right,
human
right.
to human contact. Did it help them? Hell yes, it
Yeah,
helped them. They were
yeah.
sober 4 months using virtual IOP. Absolutely, inarguable. But meeting them face to face and that human contact and that hug and the tears
Yeah.
flowing, there's nothing.
I think to your
nothing
point,
like
but the outcomes will be down the road. We won't know for sure. Effective for some, for all, no.
You also can't ever minimize the
chance.
impact, of a person-to-person contact. I mean, like, before we had iPhones and social media and scrolled all day, we used to have conversations with each other.
Yeah.
Don't get me started.
I remember it briefly. It was a brief glimpse of time. But, like, there's nothing that can replace that. I mean, connection and fellowship, that's what recovery is all about. So there's a part where once you acknowledge that piece and know that, like, you're not completely eliminating it, but you're adding something that has value, I think that makes the most sense as we're all figuring it out as we go. Like, I woke up this morning and there's a new mandate for masks again in treatment facilities that came down. So,
In what state?
the beautiful state of New Jersey.
Oh, is that right?
That
When
is-
did this occur?
4 p.m. today, 3 p.m.,
Oh,
2
well,
p.m.
that's why I've
I
been
did
here
not see
preparing
it,
for
but
this.
I'm
I haven't
I
had that.
saw it came out and it was required for like behavioral health facilities, all the state-funded facilities. So, you wake up, you open your eyes, you're pleasantly surprised by what the day has to bring. I mean, I think that is the way, and I had to learn to do that with COVID, is like embracing what the day throws at you. And I don't know, I think if we just took the approach, and I think everyone has that's doing treatment, is like, okay, what is in the best interest of getting the patient well for the long haul? And a lot of the times that was a mix, a hybrid model. Sometimes it was purely face-to-face. Sometimes it was pure virtual because of, situation. But, tomorrow might bring a new pleasant surprise our way.
Yeah.
So,
An ever-shifting paradigm, and you have
Forever.
to roll with the punches, and that's
Constantly.
and that's what we'll do. And at the end of the day, the main goal is to help the client and their
Yeah.
family. Period. That's number one. We always say that's number 1, 2, and 3 on our list of priorities.
Yep.
And then everything else is 4, 5, and 6, and blah blah blah. But it's always client and their family, client and family, client and family, or 1, 2, and 3. It has to be all.
Yeah.
And what does that look like? Whatever we need it to look like in order to keep this thing. To keep treatment coming and to keep them the eye on the ball, which is that
100%.
that addiction and that alcoholism that's killing so many people. every
Agreed.
year.
I've been doing this 20 years. This is the most dynamic time
Oh, God.
of my career.
It's live wire. And you guys have already said it. The uptick in mental health with anxiety and depression, and it's just live wire. It takes something that was already extremely problematic and it's just intensified.
Yeah.
And you Don brought up the age thing. Our age is probably over the last year and a half has gone up 10 years probably.
Oh, my
I don't
gosh.
have the numbers.
I'm with you.
But I mean the opiate during the height of the opiate, we couldn't get a 29-year-old. That was 29. Wow, and an alcoholic.
Yeah,
you know. And now it's the population has shifted the other way.
Sure.
It's probably 70% alcohol related
Yeah.
or a mix.
and
right?
60
You're right.
plus years old.
Right.
I
Yeah.
mean, the first 3 months, I remember saying to the team, because I think, again, preconceived notions. I'm assuming, okay, this is going to drive a lot of younger adults into treatment, right? Like all of the time occupiers that were of the past are now gone. So I'm just assuming falsely that younger adults are going to drive into treatment. First 90 days, I mean, influx without a doubt of older adults. Primary alcohol.
Well, let me throw something else
couldn't
out there
hide,
at you
though.
guys.
Nowhere else to isolate.
Nowhere to hide.
Yep.
I want to
Nowhere
hear.
to
I want to hear your guys' thoughts on this. And again, there's no. This is all just. We all talk, and so we have our weekly meetings with everybody, all the department heads. We're always asking ourselves, as we all have to do. I'm sure even on the individual side, and when you work out of the hospitals, they must do it as well. But we have these little bull session meetings, or what could we be doing differently?
Right.
We
Yep.
constantly asking ourselves that question because this ever-shifting landscape. We always have to be holding ourselves to account, and what could we be doing? What could we be doing differently? So some of the conversations we have that come up, and I use the term law of unintended consequences already. And one of the topics that came up recently was this very conversation of how the population has shifted a little older, a lot more alcohol. And so we talked about that, and a lot of it, there's two parts to it, interestingly, in my experience and what we've seen so far. Number one, yes, it's the at-home isolation. People are drinking a lot more. They're
Right.
doing other drugs
Yep.
more than they would ever have done it before, including marijuana, because marijuana is absolutely brutal, and it is a gateway drug, and it never should have been legalized and whatever, but that's we had a whole topic on that, but whatever.
I would have loved to have been here for that.
So, but putting that aside, people are drinking more. There's more anxiety. There's more depression. There's more of all that stuff going on. It makes sense that you'd see. Because of everything that's gone on with the law of unintended consequences and everything that's gone on with COVID, we look at and we consider the stimulus checks and the unemployment and how many of our younger heroin addicts are still out there and they've paused. We haven't seen them in many months, and they are coming to a theater near you soon because it's going to end. And when the gravy train ends and the moratorium of not booting people out of their homes comes to an end and unemployment ends and all the
September.
free money ends, the gravy train will stop. They're all out there right now. And we've seen the uptick partially because there is more of that going on at home, but also because a lot of the folks that we would normally see, the 18 to 26-year-old,
Right.
hardcore addicts are, they're
Still out there.
They're still out there, and they haven't been getting the tune-ups lately because they haven't had to. What do you?
Interesting.
I'm wondering what your thoughts on
the
that.
oxygen of that addiction is money, so they have money in other
There it is. And again, I have no
Biggest
doubt
trigger.
that the administration
aspect
could
of
never
that.
have realized there's so many. Any decision you make
Right.
has multi-pronged consequences.
100%.
All of them, not all positive. This is one of the big negatives in our field that we're starting to see the effects
Yeah.
of in a
Leaving
big
liquor
way.
stores open.
Say it again.
When everything shut down,
Yep,
leaving the
liquor
liquor
stores
stores
stayed open.
open.
Isn't that an interesting decision, right? Talk about policy decisions. I think PA, that was a big deal, right? Am I?
Are they state stores? Yeah.
I'm pretty sure the
Ours-
state
yeah.
stores all stayed
Yeah,
open,
yeah.
and some people were outraged and infuriated, whereas other people said, well, people do have to get their wine. I've heard actual politicians say, like, well, people have to get their wine, especially now.
Basic
Given
need.
what's going
It's
on.
a hierarchy
They
of
need
human
it-
needs,
Yeah,
Richie.
of course. I mean, they need it now more than ever, right?
Right up on Maslow's stuff.
So, Dawn, I would put it to you, and then maybe we can kick it all through. So, again, there's 80 million different side topics, but if you had to, speaking to anybody who's watching, and as far as the addict themselves, right, the addict and or their family, I mean, you can go to both, but COVID is scary. COVID was real. 500,000 people died
Right.
in this country alone, right?
Right.
And so it's a real thing, and it's scary stuff. But what is your take on? I mean, or just how would you put it to somebody where keeping that into some type of perspective to what the alternative is and what the actual problem of addiction and alcoholism, speak to it.
I mean, I think my call to action is really
to
like,
action,
to get help, right? Is that, COVID, as you mentioned, right? It's going to be around as the flu is, as other diseases are. But, addiction is unfortunately progressive. It's, it will get worse. It will not get better. And what I see is a lot of people delaying the inevitable. So it really is my call to action is like COVID is scary, COVID is real, COVID is 100% there, but the disease of addiction will not slow down at a slower rate because of a COVID vaccine, or if you stay home one more month to continue drinking, or if you wait until the end of September when the unemployment is up, right? None of those things will be halted for your substance use. So it's always my singular thing is like all those things are distractions because addiction is there. It won't go away and it won't stop on its own. So seek help, call a friend, call a treatment center, call somebody who can help you, because I think that's the number one thing I've seen during COVID is it has caused a lot more distractions, and I've seen people delay the inevitable, which is getting help. And it's for what? COVID will be here next year.
Yeah.
And, we'll be having the same conversation about a need for help.
Yeah.
So, that's my one takeaway is you're safe in any of these places you go. You're as safe as you are in the ShopRite, in the Wawa, or anywhere else you go.
There it is.
But the isolation and the hiding and the progression of the disease of addiction will be there tomorrow when you wake up.
Now, Mike, for you, if you don't mind, and again, I love the call to action. That's exactly the term I was looking for. But, Mike, I would ask you just to speak to, again, just kind of trying to tabulate a lot of the different stuff that we've kind of presented, that we've talked about. The person that has been home for the last year and a half, heightened stress, heightened anxiety, been drinking a hell of a lot more than they normally do, and you know who you are, and you're out there, and you're an accountant, and you're a cop, and you're a nurse, and you're a teacher, and you're all these different folks, right? Any one of us. You've been drinking for a year and a half, a hell of a lot more, and now you've realized and you've decided this has gotten out of control, I'm going to stop. Is it dangerous for somebody from 40 to 70 years old to just stop drinking after a year and a half of daily larger quantities than they're used to, just stopping drinking? Can you speak to that a little?
Yeah, I mean, it's extremely dangerous.
Don't do that.
Because you will go into grand mal seizure, and I've witnessed, I don't know if anybody, multiple times people having seizures from alcohol withdrawal. So your body is addicted to alcohol at a cellular level, and when you stop feeding that, you will go into seizure. It's very scary. And we can treat that medically with medication to trick the body into thinking you're still drinking, and it's safe, it's effective, and it's relatively pain-free. Yeah. So I invite you to get help now, and there's doing it on your own is the least effective way to do this.
So to the heroin addict, and before I go to Julie, and I'll speak to the heroin addicts, my favorite thing that was ever told to me when Nick and I had gone to, was it you and I, Nick? No, it was me and Trokey had gone to intervention training. And we went with Earl Hightower. I don't know if you guys, Earl. You know Earl? You know Earl, right? Earl's wonderful, man. Hightower Associates, they're out West Coast. Earl's astounding, right? And his favorite line to me, one of the things that he uses when he talks to people, and it's a reality for the detox world, and it's something that, especially heroin addicts, what are heroin addicts most scared of than anything else is getting sick. That 5-6 days for them is the most unappealing, most frightening. It's scarier to them than the idea of continuing to live the way they're living. And Earl put it the best way, and I use it all the time, and we always tell them, listen, when you come in, we're going to load you up on the front ends with plenty of meds, and we're going to bring you down smooth and easy. That's what they want to hear, and that's what I'm telling you. That's what we do. We load you up on the front end with all the meds that you're going to need, and we try and bring you down smooth and easy.
Yeah.
And that's available. Calling the...
And you can do it now.
Yeah.
You don't have to wait.
You can do it right now.
Right
you don't
this
have
minute
to wait.
you can do
don't
it.
have
It's
to...
Right this
You're
minute.
here and it's now.
Yeah, and it ain't going to get better.
Yeah.
It's only going to get worse. That's just the
Facts.
reality. Julie, what about you? Words of wisdom, especially maybe to the families or to the individuals, mental health side, especially with the stress and anxiety and such.
So a lot of people are hesitant to reach out to a detox or an IOP or inpatient, right? They don't want to do that. So if someone calls me and they're actively drinking, I'll talk to them, I'll see them with the intention of moving them towards the level of care that they absolutely need. The disease of addiction is progressive. It only gets worse. It never gets better. Never, ever gets better. It will get worse. The other point I wanted to make, too, is that in the hospital setting, we see people come in, they want to come to detox. The hospital is not a detox. So in the emergency room, there's a crisis department. They will, the doctors hopefully will call crisis, and crisis will, do their intervention and try to get them into a detox. But they need to want to do that.
Right.
If they don't want that, if they're not suicidal, they won't get crisis,
They go home.
to intervene. But some of the hospitals, as you know, have a peer recovery program. ORP, I'm not sure of what ORP actually stands for. It's the opioid.
Opioid
Overdose
overdose
response.
reversal program.
Okay, so ORP
Right.
was not
Yes.
was not allowed to come into the hospitals during COVID, active COVID. I believe they're just starting to get back now.
Yep.
So those individuals that came in that overdosed or that were Narcaned, they
no
either got
resources.
medicine to, get them through their first 24 hours. If the doctor saw anxiety, depression, any mental health, I don't know how you couldn't, but any mental health issues, then crisis got involved. Now, the peer recovery programs were not in every single hospital. So the hospital that I'm working in has a small program now that is started. So now we can go down and see those patients and talk to them and try to get them into treatment. So
Right.
all the treatment centers, we try to hook them up to.
And saying that you think about that in a simple form, that's one channel that addicts and alcoholics didn't have for help during COVID because they weren't running to the ED with COVID running rampant.
Right.
Right? They
Right.
weren't going there.
Yeah,
Right?
no.
So there was the crisis
Or if they
units,
went there, they were not
they were rebuffed.
treated.
Right.
Yeah.
They weren't the
that's-
They were
priority.
like,
Yeah, yeah,
okay,
Right? And they
get
were
sick.
scared. I'm not going there
Sure.
to get COVID.
Sure.
You know?
Even within the hospitals, to speak to that, it's interesting that so many, and this is kind of what my overall point was, that, 93,331 overdose deaths, but there's a lot more deaths that are alcohol related. To the ORP program, they would only send you bedside if Narcan was administered.
Right.
Yeah, OD.
If OD only.
Yeah. Right.
Now, there's plenty of other interventions that should and need to be taking place in a hospital with private client folks. There's a lot of interventions that could and should be taken. We're getting there.
Right.
But the teaching the hospital people, like the addiction doctors, we do at Blue Crest, we do the addiction hours. All interns have to have a certain amount of intern hours. So we, with Riverside Medical Group, and I don't know if I'm allowed to say you guys' name, but you guys doing it with us, so I don't care.
Shout out.
But they're coming in. Yeah, give them a shout out. Riverside Medical, we use them all the time. And Riverside Medical will send their docs in to do with our psychiatrist who is on staff full time.
Right.
And he'll do their addiction hours. So they get their internship hours with us. And if only we could teach all professionals at all areas within the hospital, from the nurses to the techs to the orderlies to
Agreed.
the social workers, to have that eye out for addiction. Because just because they came in and they had a heart attack, I wonder why, right? I wonder
Well, I
if
mean,
it
that's
was-
the true thing. The death certificate's not going to say acute
it won't,
alcoholism.
but that's
Right.
what killed them.
Right.
That's what killed them.
I agree with
And
that.
then that's why I'm
reality.
excited to hear that you're in the hospitals. I mean, it takes a lot to get a psych hold, or, we don't have that in Jersey, right? But a psych hospitalization for someone. And realistically, the more individuals in hospitals that are educated about addiction, I know for a fact, like, to me, when somebody tells somebody who's struggling with addiction, you need help and you're a medical professional, that resonates with someone way more than just, a random Joe off the street, right? It really does, because we go to doctors for help, we respect their opinion. And I really feel like in the hospitals, if we have more individuals who are educated and really strong advocates for getting people the treatment they need,
Yeah.
And willing to engage.
yeah, and willing to care about it.
Yeah.
So
Willing to care.
I'm going to speak to the policymakers, and this pandemic is the first we've lived through in our lifetime. Something like this is just mad cow and all, but this is legit. This was scary beyond belief. There's lots of unintended consequences. There was well-meaning policies that went bad, and then there were non-existing policies which should have been there. And so, I would say just look at all these things. One of the law of unintended consequences of COVID, that it had the effect you just brought up, and it was at the tail end of when we're wrapping up. But you're right, ORP. Right, when I volunteered, that's how I knew what it stood for. I volunteered for ORP in Bergen County when it first came out. Well, before we opened Blue Crest, we were in the process of opening, and I heard about this, and I'm like, I'll volunteer to do that.
Right.
Just because I'll go bedside. I want to
Yeah,
talk to everybody, right? We
Yeah.
weren't even open
Get
yet,
'em
but I'm
in.
like, and it has nothing to do with
in.
treatment. I did that as just an individual human being
Right.
to go bedside, and I said, yeah, I'll go do that. I'll volunteer to do that stuff. So ORP plays a very important role. When somebody overdoses, they have Narcan. God, I wanted to punch some of those people so bad. Your mom is crying, bro. Go to treatment. Go to rehab. And the guy's like, where's my shorts? And you're like, where's your shorts? Like, I'm not tempered well for that, right? Because I just want to throttle.
Really?
the guy.
I'm with you.
I want to throttle the guy, right? And so. But the thing is, again, policymakers, this is just one small example that Julie brought up. ORP was no longer allowed to go bedside. That's not okay. I get the COVID thing, you're right. And you do have to limit hospitals, but you don't limit ORP workers. Because ORP workers are going to addiction. We are already losing hundreds of thousands of people a year. You don't get to say we can't go help the
We
addict.
essentially say they're not essential,
Yeah,
is what we say.
Dude,
We prioritized away.
We've been in a state of emergency for decades.
Yep.
You guys are all new to this. We aren't.
Right.
We've been dealing with hundreds of thousands of deaths a year.
True.
You don't get to stop ORP. You don't get to stop PHP programs, detox programs, residential programs. We are essential beyond belief when it comes to the addiction world. We already have CNN run the tally of alcohol and drug-related deaths, including overdoses, on the top of the screen day in and day out, and let people see the reality of what goes on every day because of drug addiction.
We talked about it. The streets in New York, people were complaining about the homeless and everything else. Well, that's because they were the only ones left on the streets. So a problem that was already there
just
became really apparent.
Very obvious to everyone.
people that ignored it for years.
For years and years.
True.
So listen, I thank you guys all for coming and chatting about this stuff, and hopefully, listen, even if nobody out there got anything out of it, I know I did, and you guys were all
Same.
a super pleasure.
Thanks for
and
having
we
us.
appreciate
Thank
you
you.
guys.
It was a
Thank
lot
you
of
very
fun.
much.
Thanks.
Thank you.
Kev, thank you very much. And again, you can get us on Facebook, SoundCloud, YouTube, and Spotify. And Nick, I guess we didn't have any questions?
No, there's just a lot of people.
Just commentary and stuff? Were they saying how awesome my car looked?
Yeah.
He really does look great.
Oh,
And that's it.
stop it.
We're good?
How dare you? I have a good face for radio.
Dude, we just closed